My patient, 30 years of age, gravid to perennial with one first trimester spontaneous miscarriage. Her last menstrual period was on 15th June 2019, making her expected date of delivery 15 March 2020, and today her duration of pregnancy is 32 plus 3 weeks. She is a known cardiac patient for last 10 years back when her cardiac surgery was done and she was put on tablet warfarin. Up till now, up till her pregnancy, she was compliant to her tablet warfarin but never did her checkup from any cardiologist. She conceived this pregnancy by one cycle of ovulation induction by oral tablets, and first time visited to antenatal clinic where her ultrasound was done and she was told that she has a twin pregnancy of 2 months. And her tablet warfarin was stopped and she was put on low molecular weight heparin injection for which she is compliant and taking only one injection daily. After that, she remained non-compliant to an antenatal visit, but she was taking oral hemodynamics regularly. 15 days back, she felt shortness of breath, for which she presented to local doctor, and her ultrasound was done and she was reassured about her twin pregnancy, but she was referred to the tertiary care hospital for further evaluation and management of her cardiac disease as well as twin pregnancy. Here she has been admitted in the ward and she gives history of shortness of breath on doing household activities but is stable on sitting and lying flat. She does not give history of bluish discoloration and generalized body swelling, episodes of unconsciousness, and she is feeling normal fetal movements. On examination, her pulse rate is 80 beats per minute, regular in rhythm and good volume. Her BP is 120 by 80 millimeter of mercury, and on inspection of the chest.
Okay, we stop here. Now, what is the problem with your patient?
She is twin pregnancy with cardiac disease.
Talk loud so that it can be recorded.
She is twin pregnancy with cardiac disease.
With cardiac disease. Why do you say she has got cardiac disease?
The patient gives her history is significant because 10 years back she underwent cardiac surgery, and according to the patient, her valve was changed and she was put on tablet warfarin, which she is taking up for 10 years.
So she had valvular surgery how many years ago? 10 years?
10 years back.
10 years ago. And what do you think after valvular surgery, what is the status of cardiac function, generally speaking?
Sir, after valvular surgery, cardiac functions, cardiac compromise that was present before the surgery was stopped, and patient should be asymptomatic after the cardiac surgery. For my patient.
So after her cardiac surgery, was she asymptomatic or symptomatic?
So she remains asymptomatic.
Asymptomatic. So it doesn't mean that after cardiac surgery, the problem was solved and she did not have cardiac problem.
Yes, sir.
Right? So in our specialty, any patient who had heart disease or cardiac problem and it was treated 10 years ago, had no problem, how shall we rate her or categorize her?
Sir, we should grade her according to her presenting complaint before the surgery, but we would say now that she was in grade 2 at the time of surgery, but now is stable on medication.
So, do you know how we categorize our cardiac patients during pregnancy?
Yes, sir.
Tell me.
Sir, we grade her according to her signs and symptoms. In grade 1 mild degree, she is stable on doing her ordinary activities, but can get exertion on extraneous exercise. In grade 2, she has mild limitation of the physical activities, but unstable on sitting and lying down. In grade 3, she is only stable on sitting and she cannot carry out her ordinary household activities. And in grade 4 she is stable only at she is not stable even at on sitting or lying.
Any patient who gets shortness of breath, even while lying in bed, what is the medical terminology we use for that?
Orthopnea.
Orthopnea. She is orthopnic. Okay, anybody who is in grade 4.
Yes.
In which category you will put this patient?
Grade 2. Grade 2.
2. Why you say grade 2?
She gets breathlessness on doing her ordinary physical activities like doing her...
Was that the status at the beginning of pregnancy?
No, sir.
Before pregnancy?
No, sir. She was stable before pregnancy and...
So, before pregnancy or early part of pregnancy, she was what?
So she was doing her household activities.
What category we will put her in at the beginning of pregnancy?
So grade 1.
1. So 1 is the patient who has a history but no symptoms.
Yes.
She had no symptoms. And she was put on warfarin. Why was she put on warfarin?
Sir, because she underwent cardiac surgery and her prosthetic valve was placed, and after that she was put on anticoagulant.
So warfarin because of prosthesis she has. Very good. And why was she changed from warfarin to heparin, long acting?
Sir, according to my view, at 2 months of the gestation, there was no need of changing from warfarin to heparin, because warfarin is teratogenic, embryopathic, and it's according to the evidence says that 7 to 12 weeks its teratogenic effects are maximum. But she attended some local antenatal clinic, and that is why her warfarin was changed to low molecular weight.
Now, what stage of pregnancy she consulted local doctor?
Sure, when she was 2 months pregnant.
2 months. 2 months means? 2 months
yes,
means?
Sir. Sorry, sir. 2 months means 8 weeks.
8 weeks.
Yes, sir.
So it was still worth it.
Yes, sir.
Okay. Now, if she had come to you in 4th month of pregnancy, would you change her warfarin?
No, sir.
No.
No, sir.
Why don't you want to change it? Warfarin is if the baby is born with some anomaly, the patient will tell you, why didn't you change my drug? It is because of that. It will be difficult to convince her.
Yes. Sir, it is written in the books, but because in that warfarin is teratogenic and embryopathic, maximum 7 to 12 weeks.
Anything which is teratogenic will affect in first 6 to 8 weeks. I agree with you. So, but I would imagine that even if she comes later than 8 weeks, after 12 weeks, for clinical practice it is better to switch over from warfarin to something else, because we don't have statistics where warfarin was given after 4th month and it was okay. If we don't have data, it's better to change over to warfarin. Okay. And with change over to, what is the dose of this heparin which she is having?
Sir, she was not knowing about the exact dose of...
If you had to prescribe, what will be the dose?
Sir, I will prescribe her therapeutic dose of the low molecular weight heparin, and that is 60 milligram per day.
Per day, subcutaneous.
Subcutaneous.
All right, that's the cardiac part. Now we come to the obstetrical side. She is twin pregnancy.
Yes, sir.
And now she is 32 weeks, isn't it?
Yes.
Today she comes under your care. How will you manage this patient?
First of all, I will tell the patient that it is a high-risk pregnancy and has risk to the both mother and the fetus. Mother is at risk of cardiac failure, pulmonary edema.
Because of heart disease?
Yes, sir.
I would imagine for 10 years, if she has been all right, and no symptoms, and she was in stage 1. Very unlikely that she will go into failure. I grant you this much, that during pregnancy, heart disease deteriorates one step. Her grade 1 changes into 2. If she was at 2 in the beginning, she would have become 3. If she was 3, it would have become 4. But she was well enough. Okay.
She has an increased risk of developing hypertension in pregnancy and anemia.
Hypertension because of her heart disease?
So twin pregnancy.
Because of
Twin pregnancy.
they are the complications of twin pregnancy. Yeah, okay.
And she is also at increased risk of developing anemia, and after delivery, intrauterine growth restriction of her baby, and preterm delivery, and after pre-prom, and after delivery she has at increased risk of postpartum hemorrhage, and she is likely to at increased risk of cesarean section and instrumental vaginal delivery, prolonged labor, and baby is at risk of intrauterine growth restriction and iatrogenic preterm delivery, spontaneous preterm delivery.
Now, in this case, it is twin pregnancy.
Yes.
And at 32 weeks, let's say both babies are same size.
Yes.
What are the special risks because of being twins?
So at same.
This is a patient who is at 32 weeks, and on examination or even on ultrasound, both babies have similar size. They both are same weight.
Yes, sir.
So what are the risks known to this pregnancy or the babies?
So babies are at increased risk of preterm delivery
Good.
and preterm rupture of membrane,
Yeah.
stillbirth,
Stillbirth. Why?
because her evidence says that the risk of the stillbirth in twin pregnancy is more as compared to the singleton pregnancy.
Is stillbirth more common in first twin or second twin?
So in secondary,
Why? Yeah, you're right. Why in second twin?
for exact reason I don't know.
Because when we allow twin pregnancy to deliver vaginally, answer this question, then we'll.
First monochorionic pregnancy and no baby is having any complication, and first twin is cephalic presentation.
When first twin is cephalic presentation. And what happens with the first twin when the baby comes out? What happens to the second baby? You have delivered the baby, cut the cord, second is still inside the uterus.
So malpositioning of the second baby.
Malpresentation. Malpresentation. Whenever there is malpresentation, the risk to the baby is higher. That's why stillbirths are in the second twin. Okay? You have delivered the first baby, second is, let's say, transverse line. What will you do?
Sir, if the membrane are intact, then I will do her external cephalic version of the baby. And if external cephalic version is not possible, the baby has bradycardia, some cardiac bradycardia, her in fetal distress, then I will do her internal cephalic version of the baby and deliver baby by breech extraction.
What do you think of doing cesarean section for the second twin in situation like that?
Sir, if these maneuvers are not possible, external cephalic version, internal pedalic version, then and the baby is not delivered by spontaneous vaginal delivery, then I can go for C-section. But this is.
Wait a minute. I said second baby is transverse lie. You said I'll try external cephalic version. You're right. And you went on to say if the baby is bradycardia, and then you'll do internal pedalic version.
Yes, sir.
That's your first choice.
Yes, sir.
I say my first choice is do cesarean section. What do you think of that? What is recommended management in such situation? Is it cesarean section for the second twin, or is it internal pedalic version and breech extraction?
Sir, safest option is C-section, but in practice and internal pedalic version is.
You think that's preferred?
Yes, sir.
Have you done it?
No, sir.
Generally speaking, if there is fetal distress and transverse lie, preference should be
C-section.
cesarean section. Internal pedalic version exposes that baby to extra stress.
But sir, in ideal situation, if the mother
We are talking about
in
in examination,
Yes, sir.
the situation is always ideal.
Yes, sir.
Always ideal.
Then sir, I should go for C-section.
Oh, okay. Better to cesarean section. We go back. If this patient had come to you very early, about 8 weeks of pregnancy, what are the risks which you will tell her that twin pregnancy has?
So twin pregnancy has increased rate of miscarriage, increased rate of congenital anomalies, increased risk of developing anemia, hypertension and diabetes to the mother, and babies at increased risk of intrauterine growth restriction and preterm labor.
What do you think, what kind of twins carry higher risk? Is it monozygotic or dizygotic?
Sir,
Or monochorionic?
Monozygotic twin are carry high risk.
What are special risks to those twins?
So monozygotic twin carry increased risk of the congenital anomaly as compared to the dizygotic twin, and the monozygotic twin are also at increased risk, higher chances of monochorionic pregnancy and as well as monoamniotic, that is although rare but can occur, and these two conditions.
What can occur?
Monoamniotic, monochorionic.
Monoamniotic?
Monochorionic.
Monochorionic, yes, that's possibility.
And these two conditions are at high, likely increased risk to the baby as compared to the dizygotic.
What are those increased risks?
So intrauterine growth restriction, anomalous baby, polyhydramnios in twin transfusion syndrome, reverse anemia.
Very good. Twin transfusion to each other. And what are the consequences of twin-to-twin transfusion?
In twin transfusion syndrome, basically there is imbalance between the circulation of the two babies. One baby is having more circulation, more blood flow, and other baby is having less blood flow. The baby that is having less blood flow at increased risk of the intrauterine growth restriction, and that having increased blood flow at increased risk of polyhydramnios and hydropic fetus as well.
Hydropic may not be, but increased polyhydramnios and polycythemia.
Yes.
Okay. How will you manage a patient if you suspect there is twin-to-twin transfusion?
So the patient with twin transfusion syndrome is managed according to the gestational age. The cutoff limit is 26 weeks of the gestation. Before 26 weeks of the gestation, if the baby has twin transfusion syndrome, then the best option is laser ablation of the abnormal communication. And after 22 weeks, we can do, if it is possible, by fetal-maternal medicine unit. Otherwise, amnio reduction is the choice.
Suppose very early one baby dies and other one is still alive. How will you manage? How will you go about it?
So Sir, the intrauterine death of one baby and the other alive baby is different scenario in monochorionic and dichorionic. In monochorionic, because the vascular communication is there, so the risk to the live baby is more as compared to the dichorionic baby.
What are the risks?
Risk of the intrauterine death of that baby and neurological abnormalities to the live baby.
Very good. So, what can you do if monochorionic and this thing happens? What can you do?
Sir, if the death of the one baby immediately is perceived within 24 to 48 hours, then I can transfuse the surviving baby.
Transfuse?
And if
is the baby at risk because of lack of blood in that second, the living baby?
When the death of the one twin occurred, then the compensatory response, rapid transfusion to the dying twin occurs, that result in hypotension of the live twin, that results in the neurological abnormalities of sudden hypotension to the living baby, and that result in neurological abnormalities to that baby.
So what will you do?
Sir, if the age of maturity has been reached and that is 32 weeks of the gestation, then immediately I will deliver the live baby and secure her life from risk of the intrauterine death as well as neurological abnormalities. But if the time has passed and 1 week, 2 weeks, and I am not sure that at which gestation the intrauterine death, at which time intrauterine death of the first baby has occurred, then I will continue the pregnancy with the counseling of the parents that living baby may be at risk of neurological abnormality as well as intrauterine death, and I will monitor for coagulopathy of the living baby by doing her.
So you said 32 weeks. Can we bring it back? The baby is viable. Viability in the West is 24, with us 28 weeks.
Yes, sir. If the nursery facilities are maximum and the baby has live baby has weight above 1 kg, then I can deliver her by C-section.
What will you do before delivery? Any special measures? Will you give Decadron to?
Yes, sir. I will give Dexa cover.
Dexa cover can be given.
Yes, sir.
Okay. Another situation that these days ART, you understand what is ART?
Assisted reproduction.
With that stimulation of the ovaries, multiple pregnancies are more common.
Yes, sir.
Not only twins, triplets, even quads. And suppose a patient comes to you with the pregnancy of 4 babies. After stimulation of the ovaries, she has conceived. Now there are quads, 4 babies inside it. How will you manage that patient?
Sir, I will manage that patient by selective fetal reduction of the baby. If that patient comes early in the pregnancy, then I will do selective fetal reduction to up till twin pregnancy, 2 babies.
How will you do this?
Laser ablation of the cord.
Hardly any cord. Those early.
Intracardiac injection of the potassium chloride.
Yeah, good. But before giving this injection, will you do something very important?
Yes, sir, I will confirm chorionicity. If monochorionic, then
even before that.
Sir, congenital anomalies
You obviously you mean it, but you haven't said it. You will counsel your patient.
Sir, counseling the patient.
She may be willing, she may not be willing.
Yes.
I'll counsel my patient
Yes.
that we are going to do fetal reduction. Right?
Yes.
Okay. And suppose another situation. Patient is, say, 12 to 14 weeks and it was twin pregnancy up to that, but at 12 weeks, one baby has died or disappeared. What will you do?
Sir, I will continue the pregnancy.
You will continue the pregnancy. I agree with you. I agree with you.
Yes, sir.
Anything else?
Sir, I will consult the patient that vanishing twin.
That is first thing. That is the first thing. How will you counsel your patient in this situation? What will you tell her?
I will counsel the patient that in early pregnancy, if the one twin is IUD terminate or disappear, then in twin pregnancy it is likely chance and 25% of the twin pregnancy that one baby get vanishing twin, but there is minimum risk to the live baby. So we'll continue with the pregnancy with close monitoring.
Is the baby survival of that baby is affected by the death of this one baby?
Sir,
Is he at risk or not?
Sir, if vanishing twin syndrome has occurred early in the pregnancy, that minimum risk.
There is some risk, there is some, but not as much as in late pregnancy, and not as in late pregnancy. Okay, we come back to this patient. He delivered the two babies and they are okay. What are the risks during third stage of labor to this patient?
So, during third stage of the labor, baby mother is at risk of the cardiac compromise, cardiac failure, and at risk of the postpartum hemorrhage, because you say
Postpartum hemorrhage, twins, postpartum.
Yes.
What measures will you take?
I will do her active management of the third stage of labor by controlled contraction and by giving her the injection syntocinon 5 unit.
What time?
To the delivery of the second baby.
After completion of the delivery of the second baby, or
After delivery of the shoulder of the second baby, then I will give.
halfway almost, you will give. Okay, and suppose the patient gets postpartum hemorrhage after delivery, which is quite common after twins. What measures will you take immediately?
Sir, I will prop up the patient, and because this is cardiac patient and this is already in proper position, I will give oxygen to the patient as well as I will pass to whiteboard cannula because patient is has in PPH, and I will do the control contraction has already occurred. I will do bimanual compression of the uterus to prevent the postpartum hemorrhage to cure, and as well as I will start concentrated
Bimanual compression, or is it called fundal massage? What's the difference between the two? Compression is there,
compression is
but
better than
fundal massage. You will not do fundal massage.
Sir, I will do fundal massage as well, but bimanual compression I will keep. That is more.
Okay. Patient continues to bleed.
Sir, I will start her concentrated unit of the syntocinon in 500 ml of the saline with 30 unit of the synto, and as well as I will put 400 milligram of the tablet misoprostol per rectal, and
anything else?
As this is high risk patient in pregnancy and in labor, I will and cardiac patient, I have already arranged blood for that patient. Then if she continue to bleed, then I will give her blood transfusion in the form of packed cell volume with the Lasix cover, under Lasix cover.
Suppose that she doesn't stop bleeding. PPH is very serious.
Sir, then I will try balloon tamponade method.
Very
If,
good.
bimanual compression is not.
What's the name of that balloon?
Sir, bakery balloon.
Bakery, yeah, right. Okay. And patient is still.
So then I will do laparotomy and I will do Baylin's and uterus securing measures. First of all, I will do balance. I will apply the balance to the uterus and try to control the hemorrhage.